Good morning. It's really a pleasure to see so much interest in refractive surgery. So we start this session with the basics and we talk about how to optimize a LASIK procedure. An Indian married woman wears a red dot on her forehead. And have you ever wondered why? And somebody answered me saying that she's recording everything. When you are trying to do LASIK, your attitude should be like an Indian married woman. And you should be recording every little step, every little thing, every little change that you do in your procedure, in the way you talk to the patient and the way you conduct yourself. So steps in optimizing LASIK starts right from pre-op, continues intraoperatively, and it requires a lot of hand-holding if the patient is in trouble post-operatively. So we start by selecting the right patient. Over time, I have realized that there is a limitation of the technique, and it's not generally a good idea to treat more than -12 on the myopic side and +6 on the hyperopic side. And there are very good lens-based methods that are available today, including the ICLs, which you can use for these extremes of refractive errors that come your way. This is because of several reasons. If you try to modify the corneal curvature too much, and if it goes beyond the physiological limit, it's not going to remain any longer any stable, and you would be surprised to find refractive outcomes which are not what you expected. Secondly, even if you find that the refractive outcome is pretty satisfactory, you have changed the curvature so much that you are going to now affect the tear film, and the tear film will no longer be that stable, along with inducing a lot of higher order aberrations. So it's a good idea to stick to only the levels which is comfortable for the cornea to handle. Pre-operatively, it's also a good idea to rule out form-frestic keratoconus or pellucid marginal degeneration. And it is not only a diagnosis from the topography. There is no substitute to doing a topography, but I would also look at other things, other clinical data that face few. You should look at the symmetry between the two eyes. You would rarely find a difference of more than a diopter between the two eyes in a normally occurring eye. Or you would rarely find a difference of more than 10 microns of pachymetry difference if the eyes are at a normal level. You can also carefully look for scissors shadow on retinopathy, and it goes a long way to diagnosis the keratoconus even before you do a topography. You have to keep in mind that cornea resists this change of shape from 35 to 49 diopter, and therefore you should avoid these extremes and not induce a lot of higher order aberrations. And on a lighter note, you should have a high rejection for lawyers, police officers, income tax officers, people who can trouble you later on. Refraction is of course very critical. You have to do a cycloplegic refraction for hyperopia, and in myopia it's okay to select the manifest refraction, but people above 30 years of age, you should be careful, and maybe you would want to undercorrect slightly by 0.5. I use a femtosecond laser wherever available, so making the flap correct is very important, but affordability is always an issue. So it is not necessary to use a femtosecond laser only for making a flap formation, but if it is affordable, it is offering a lot of advantages today. You can have a very precise flap of a very precise thickness, and the inverse bevel side cut helps you to retain the biomechanical stability, also induces less aberration. In any case, even if you are using a microkeratome, it's a good idea to make a very well-centered flap. This will not only help you in your primary procedure, but it will also help you in case you need to do a retreatment in future. Because to my experience, even after 14 years, I've been able to lift a flap very easily, which means that you can do an enhancement anytime in life if you have properly recorded the initial flap formation, and if it was proper, it was of good size, good thickness, having a good exposure, you could do an enhancement even later on without having the need to cut a new flap, which can have many more complications. Make sure that the flap is large enough for the optical zone selected, and you should have aspheric profiles used for almost all your patients, and they would require larger optical zones in order to have the transitions and the smoothness at the end. You have to pay attention to the astigmatic axis, because you would find that when you actually ablate, it's an oval ablation when you are treating a pure cylindrical error treatment with a larger optical zone along the flat axis. So when you are placing the hinge, be very careful to have enough space so that you can do a good job. And you should completely avoid ablating the hinge because in case you ablate the hinge, it would lead to an ablation on the underside of the flap as well as on the stromal bed, which would lead to an asymmetrical astigmatism, which no amount of topolinking will also help you solve. Make sure that the treatment is completed fast. So once you open the flap, you should not wait too long, otherwise you would have a refractive problem, and that the flap doesn't become very dry. And after the flap is replaced, I avoid touching over the flap because that would disturb the epithelium. It's enough to just put a wick on the sides and extract out excess fluid and do some form of ironing, maybe with the angle of the cannula, or I like to put a drop of viscoelastic in the center, which keeps the cornea even lubricated in the initial post-op period. Ideally, if you are ensuring correct centration, you should use the visual axis as your guide. But in myopia, since the angle kappa is small, it's okay to use the pupil center as a center of treatment. But for hyperopia, it's mandatory that it is on the line of sight, because we have realized over a period of time that we induce coma if we use pupil center for treatment in cases where there is large angle kappa. Make sure that your head is completely parallel to the ground. Most of us cataract surgeons want to keep the chin up, and that would decenter the treatment down. And therefore, I don't like to completely drape the face, and even if I drape, it's a transparent drape so that I know that my face is parallel to the ground and it's also straight. Otherwise, you would be treating a totally wrong axis. And make sure that the patient is looking at coaxial illumination before switching on the eye tracker in order to make a good centration. You should also choose the appropriate ablation profile. You should use the aspheric profile in every case because that would retain the prolicity of the cornea, thus reducing the induced aberration, and therefore the patients would not have night vision difficulties. There are very few incidences in a virgin eye where you would actually need to use a true customized wavefront ablation or a topo-guided treatment. So only where there is a clear evidence of corneal irregularities or higher order aberration being present, I would not really want to use wavefront guided ablations because they consume unnecessarily tissue without any real much advantage over the aspheric or the optimized profiles. And I tend to use the customized mode much more when I'm treating as a retreatment. You should choose the right optical zone. Luckily for most Indian eyes, there are smaller pupil size. But you would be surprised to find that sometimes pupils, even in Indian eyes, dilate up to more than 6.5 to 7 millimeters. If there is a compromise to be made between tissue limitation and optical zone size, you could go down to the optical zone of 6 millimeters but not less, because a 6 millimeter zone size is an ideal zone in which, because of the Style-Crawford effect, there would not be any glare or halos. In hyperopia, it's a good idea to do as large a treatment for stability of the tear film as well as the treatment. And for high astigmatism, again, you have to be careful and choose a higher zone. DLK, if it occurs, it's not just enough to give steroids. It's always, if it is beyond grade 1, it's always a good idea to do a wash and then give extensive steroids. And for avoiding DLK, it is important that you are minimizing all changes in the OT. So simple things like changing gentian violet marker brands has also resulted in toxic keratopathy. And if there is patient unhappiness, you should add artificial tears, and that works almost in most of the cases where people have developed slight irregularities of the tear film. If there's any epithelial problem, you should tend to use preservative-free modes of artificial tears. In conclusion, I would say that creativity and having constant good outcome out of your LASIK procedures don't really go hand in hand. So it's not a good idea to keep changing your procedure, your technique, and each and every case. In fact, if you want to change, it should be a very small incremental change and one step at a time in order to get a good, constant refractive outcome from your LASIK procedure. So I think in this term, KISS works the best. And don't get scandalized. I don't mean KISS in terms of KISS. It's an acronym. Keep it simple, stupid. Thank you.